Welcome everyone to this month's installment of the Ontario NEAR webinar series. My name is Shanti Aguilar Cardenas, and I'm a research assistant here at the Ontario NEAR. And I'm joined this morning by our elder and knowledge keeper, Clayton Shirt, and our guest speaker, Dr. Brenda Restoule. So before we begin the presentation, I will invite Clay to do our spiritual opening for us. Miigwech, Clay, thank you so much for that beautiful opening and for getting us started in a good way this morning. So just a few housekeeping things before I pass it over here to Dr. Restoule. This presentation is recorded, so it will be available on our YouTube channel, and feel free to share that with your networks. If anyone wasn't able to join us today, they can watch it at a later date. And we will also have a survey that will pop up once the presentation is over. If you could please take a few minutes to fill that out for us, we would really appreciate it. And lastly, you can type your questions into the Q&A throughout the presentation. And if you prefer to speak, you can also raise your hand, and then I will enable the speaking function for you. Okay, so with that, I will pass it over to you, Brenda. Thank you so much.
Thank you, Miigwech, Shanti, for the opportunity to come back into this space and to make a presentation today. And Miigwech to our traditional practitioner, my friend Clay, for the beautiful prayer and the reminder about doing the work for the people. That struck for me today, the reminder about our work for our people to live a better life. And this presentation is going to talk a little bit about that in terms of what we experience as we attempt to live a better life and the challenges and what are some things we can do to address that. So I will start my presentation in a moment, but I guess I should maybe introduce myself. I did tell Shanti I would do that. Ani Bojo, Wapsaquestijnakaz, Magizi Dodem, Ki Kandot Donjaba, Nishnabé and Dao, Debendigo Saking. Good morning. I'm Brenda Restoule. I am the Chief Executive Officer of First Peoples Wellness Circle. I come to you today from the traditional territories of the Nabizing Nishnabek people in the Robinson Treaty. I am a citizen of Dokis First Nation, which is really across the lake from where I currently live. I grew up in Dokis and still call it home, even though my current place of residence is in Nipissing. Nipissing is like a second home to me. I am a clinical psychologist by training. I have worked pretty much my entire career with Indigenous people, primarily in First Nations communities, but I've also worked in an urban center, at an Aboriginal Health Access Center. I worked for a period of time in children's mental health, and I also worked in the correctional system very early on in my career, and that's where Clay and I met and worked with his beautiful mother as she supported women in federal institutions. A long time ago, it seems like now. I've also had the distinct honor of working as a research assistant with the Royal Commission on Aboriginal People, again, early in my graduate years. And I do a lot of this. I do a lot of speaking engagements. I also have done some writing, whether it be in journal articles or book chapters or training manuals. And I have the great fortune of working with our people across many layers of these systems at national levels with other national Indigenous organizations through the First Peoples Wellness Circle, but also at provincial levels here in Ontario and also at the community level. And I think each of those feed my spirit to help the people in different ways. And so I'm really pleased today to talk to you about some work that we did as First Peoples Wellness Circle, looking at information on anti-Indigenous racism. And we received some funding through Indigenous Services Canada to explore anti-Indigenous racism in the mental health and addiction system. And we did this in partnership with our sister organization, Thunderbird Partnership Foundation. And I often do this presentation, or have in the past done this presentation with my colleague, Dr. Carol Hopkins. But for today, I will be leading this conversation and will tell you a little bit about Thunderbird. So I'm just going to put this in slide mode and we'll get started. If it'll let me do that. Here we go. Okay, so what we have is a report that we've put out called What Justice Looks Like, and it's looking at confronting anti-Indigenous racism and building safe and comprehensive care in the mental health and addiction systems for Indigenous people. First Peoples Wellness Circle is an organization that is Indigenous led by various Indigenous leaders, mainly First Nations and some Métis. We do not have Inuit on our board at this time. And we have a mandate to implement the First Nations Mental Wellness Continuum Framework. And some of our key activities have been about building the capacity of the mental wellness and trauma-informed specialist workforce. And we do that through training, developing resources, putting out toolkits, and creating reports that help build knowledge and evidence about how to support wellness in our communities. We use Indigenous knowledge to guide how we do our work in research and evaluation. And we are committed to looking at how we can create systems change to ensure our people have access to the services they need that come from their own evidence and their own knowledge. And so much of our work is about knowledge exchange, including talking about best practices and helping strengthen the network of the Indigenous mental wellness workforce in this country. We have a strategic plan that talks about hope, belonging, meaning, and purpose. I won't read those to you, but rather encourage you, if you'd like to know more about us, you can read up about our strategic plan on our website. And our sister organization, Thunderbird, is also a not-for-profit organization who work with First Nations to build capacity in First Nation communities around substance use and addictions, and also speak a lot about mental wellness. And so often people confuse us, especially Carol and I, thinking we work in the same organization or that we are each other, because we have a lot of similar messages, but their focus remains in the area of substance use. And they get their mandate from three main frameworks, the First Nations Mental Wellness Continuum frameworks, such as us, and both her and I are co-chairs to the implementation of the framework. The Indigenous Wellness Framework, which is a framework that was based out of research looking at culture. And the third is Honoring Our Strength, which is a renewed framework to addressing substance use amongst First Nations. And they also have a strategic priority that runs the same period of time as us, from 2024 to 2029. And again, I won't read through theirs, but encourage, if you'd like to know more about Thunderbird, to go to their website to read about their strategic priorities. So I'm going to talk today about funding we received from Indigenous Services Canada. Around the time of Joyce Echaquan's death, the federal government engaged in a lot of dialogues around anti-Indigenous racism in the healthcare system. And at that time, the focus was very much on what I'll call physical health. It was on the medical profession. They heard from physicians and nurses, midwives, those who we often find in hospital settings or providing that type of healthcare. But much of what they were sharing resonated very much with some of my experiences and those of Carol's in the mental health system, whether that was what we were hearing by people that we were serving in our communities, or by ourselves as Indigenous people accessing the mental health system personally, or as navigators and advocates, or even in the work that we do and in our graduate training. And so we propose to look a little bit more specifically at anti-Indigenous racism in the mental health and addiction system, because we understand that many of our people end up in the health system because of mental health and addictions challenges, because these are seen at higher rates in our communities. And so it was meant to really respond to the call for justice and change, and to begin to think about what are some of the needs to address racism and anti-Indigenous racism in the mental health system. And so these dialogues were given an opportunity for people to speak uniquely about navigating the mental health and substance use system. We did this work through summer and early fall of 2023. And we were looking to do a few things. The first is we wanted to understand better the experiences and perspectives of First Nations, Inuit, and Métis people about anti-Indigenous racism in the mental health and addiction sector, both in a practice context as well as a training context. The second was to identify any existing best or potential interventions or approaches to respond and prevent anti-Indigenous racism in these systems. And the third was to develop key factors and recommendations that could be actionable strategies for various groups to take up, like government and even professional associations and training programs, as well as policymakers. And so our approach was to host roundtables. The majority of our roundtables were hosted in September. We had these sessions were approximately 2 hours in length. They were semi-structured and conversational in nature. We hosted a total of 5, and we had one in-person focus group. We had a total of 96 people from across the country participate in these conversations. We attempted to keep our numbers below 20 in each of these sessions, virtually as well as in person. I think our in-person one was the largest, so that there would be opportunity for people to share. Our in-person one was hosted a little bit differently. The questions were the same, but people rotated through small group discussions to be able to speak about them. Whereas in the virtual sessions, it was a large group conversation. And you'll see here the numbers varied. We had some small numbers in certain places like Saskatchewan and New Brunswick and Quebec and Newfoundland. And then we had some large numbers in places like BC, which is where we held the focus group during Healing Our Spirit Worldwide, and in Ontario, but also we had some fairly decent numbers in Manitoba. The project happened over a very short period of time to attempt to meet a timeline within Indigenous Services Canada to be able to talk about some of the needs. And so that's why it didn't get extended to increase our numbers. However, the participants we did hear from, we asked them to self-identify. You'll see that the majority were First Nation. We had a small number of Métis, a few that identified as non-Indigenous, but were working in Indigenous fields, and then another group that did not disclose, that we note as other. The folks that we heard from included those in the workforce, whether they be in mental health or addictions. We also heard from health directors, cultural practitioners, youth workers, and counselors. And people reported that they worked in a variety of settings. So some worked in community or health organizations, a few worked in universities, and there were also some that worked in Indigenous organizations, both political and advocacy organizations. You'll see from this list that we did not have any Inuit representatives. We made many efforts. Our timelines made it difficult because of September being a very important time in Nunavut and with Inuit people around some of the work they do. And so we weren't able to engage them. And we didn't hear from the North in the ways that we had hoped to hear from. We also hosted some surveys, And in these surveys, it was done as a post-engagement survey following the completion of the virtual or in-person sessions. And they got 5 questions that were very much similar to the conversations or the questions they were asked during the roundtable, in case they had more that they wanted to share. And so we distributed it to all participants, and we heard back from about half of them, around 50 responded, giving us further information. And when we were doing these roundtables, we were doing manual transcription and recording as well to get as much information as we could. And then we manually manually coded the transcriptions in themes to be able to better understand what we were hearing. And we used an Indigenous-based approach to explore themes. So really looking at things from a holistic worldview context and strengths-based. So we had a few results. This is one of our quotes that you'll find in the report that talks about a general perception of what most participants said to us. They felt that the response to anti-Indigenous racism in Canada has been, for the most part, performative. They don't see that it is tending to racism or addressing stereotypes, and that assumptions that are built in education and health systems are not being properly addressed, and rather see it as almost like a checkbox, and that there isn't transformative change happening. And so a real sense that there's lots of talk, but not a lot of action to the work on anti-Indigenous racism in Canada by September of 2023. We heard a few main key points. The first was that there was by having an absence of service, it in fact says that racism is a huge issue. The fact that Indigenous people cannot get access to the types of services they need, that they're not adequate, that they're not culturally safe, and that there is little access to things like aftercare, particularly around the crisis of substance use in our communities, where the risk of relapse is high. It was seen as a racist act that we are not being given the types of service we need to properly address the mental wellness needs and priorities of our community. The second thing we heard was that much of government is currently hiding behind jurisdictional ambiguity. So we were hearing that when people are going to access service, there continues to be confusion and ambiguity about who's responsible to provide mental health and addiction services in First Nations communities or to First Nations people. And so that's resulting in a denial of care when they say, sorry, you live in a First Nations, we can't provide that service to you. You have to go back to your community to get it. Or if we were hearing that provincial systems don't have an obligation and responsibility to provide appropriate care to First Nations and Inuit people because we are a fiduciary responsibility and therefore denied care. Those were seen again as racist actions against our people in terms of accessing not only care, but in terms of seeking wellness. The third we heard was about colonialism being perpetuated through existing and current funding policies. So we heard lots of people talk about the current funding mechanisms that are in place in terms of decisions about funding based on population instead of need, the determination of not of flowing money. So federal dollars are flowed for mental health and addiction services to the province, and then it's at the province's discretion how they choose to flow money to Indigenous communities. And so all of those are very colonial in nature in terms of decision making happening outside of our communities and outside of our control. And the decisions about what types of services they will invest in and how they'll invest in those services we're all seen as ongoing perpetuation of colonial mindset and colonial decision making that disempowers Indigenous communities from taking control of their health and seeking and being able to be empowered to make decisions about how to best access and support people in their well-being. We heard that the funding structures, as I mentioned earlier, that is based on a population basis as opposed to a need basis, continues to challenge our communities to be able to provide the adequate care and supports they need. So that means that in our communities, we aren't finding that we have enough money to hire enough people to do the work, first off, that we're not adequately paying them for the complexity of work that they're asked to do, and that we aren't being given the amount of money we need to bring in the amount of specialized resources we need. And so I'm not just talking about things like psychiatry, which we might think about from a mental health system, but many of our communities are very interested and wanting to use land-based services, but it is not being adequately funded to be able to really put the amount of resources that is needed into properly implementing a land-based program. And so they don't have the dollars they need to be able to do that. We also heard that all of these funding policies continue to reinforce and perpetuate the inequities. So whether that's there's lack of wage parity, lack of investment in adequate resources. We've also heard the opposite, that sometimes any funding that's given to First Nations communities, the expectation is they do more with less. So a program off reserve may be funded to see 40 individuals in a year, and a First Nations community may be asked with the same amount of money to see 50 people, and disregards the complexity in our communities, and disregards sort of the holistic nature in which we address people, which requires, I think, a longer length of intervention and care for our community members. We also heard that racism has generated avoidance. So when our people experience racism in the mental health and addictions field, we hear that they are much less likely to be interested in going forward and accessing services. Even though they are limited and may be able to get access, they feel that so much of the barriers they experience, whether that be the colonial barriers, the funding barriers, the lack of resource barriers, along with racism, makes people less likely to seek out services, which then perpetuates our ill health that we experience in mental health and addictions, and further perpetuates, I think, the crisis that we see, because people are not willing to go and get access to care in a system that just doesn't meet their needs. We also heard that racism has led to overall poor care of our relatives. So we heard lots of accounts of racism that has negatively impacted the quality of care that people perceive they're getting, and as a result, again, leads to that avoidance of accessing care. They talk about that there are pervasive stereotypes around Indigenous people. So those stories of people going in for a health condition and being misinterpreted as being intoxicated as one of them. But many of what we also heard was the lack of access to care because we are seen to potentially be drug seeking. So those stereotypes about drug seeking, so not adequately providing care around like pain management, for example. And so getting insufficient care or refusing to prescribe certain medications because of those stereotypes mean people are not getting the type of care that they require. And ultimately, there was a general sense that there is a lack of trust in the mental health and addiction system, as well as the providers in those systems, because they are led by stereotypes and they're led by misbeliefs about Indigenous people and well-being. So we had a number of recommendations that came forward. The first was in the area of systems transformation. So And the second was in the area of resistance and reclamation. And I'll talk a little bit about those. In these two areas, the first thing we heard was it's absolutely mandatory that there be anti-Indigenous racism and cultural safety training, that doing one by itself isn't enough. So can't just do cultural safety training, but it does have to look at getting at things like oppression, sort of white privilege, and biases, that all of those are important. And it really needs to be built on a meaningful and reciprocal relationships with the local Indigenous communities and organizations, so that it should be built together. It should be built on local knowledge and local experiences to understand the experiences of people coming through their doors in the mental health and addictions field. And it needs to be offered from a strengths-based perspective. So really about building allyship as part of that. And there needs to be discussion in these trainings around an intersectional approach to understanding both structural and interpersonal racism and discrimination, both at a systems level as well as at a societal and a personal level in the systems, to be able to shift people's understandings and their values and beliefs in order to actionize better healthcare. The second thing we heard was it's important to build an adequate and sustained capacity for self-determination within our system. So really looking at how can Indigenous communities be self-determined in providing and making decisions around mental health and addiction services, and that it needs to be adequately supported and resourced, and have capacity, whether that's at a human resource capacity level, a funding capacity level, and policy level, to be able to make changes within the current system. There needs to be forms or systems, I guess, of accountability and justice. And so we heard lots of people say that we can't leave the health systems or the professional associations to determine if they're making a difference. This needs to be something that is surveilled and assessed by Indigenous people. So there needs to be Indigenous-led processes and evaluations around whether there are real meaningful changes being done in the mental health and addiction system. It needs to include engaging regulators and licensing bodies to have expectations about the mainstream service providers taking anti-Indigenous racism and cultural safety training on a regular basis, some form of sort of assessment to see about their shifts in providing care in more culturally safe ways and reducing racism and discrimination. And so in expecting our licensing bodies and our regulators to put that perhaps in their licensing exams and in their regular assessments, and that there needs to be a continual monitoring by these licensing bodies, that this is an ongoing process and not a one-time checkbox thing. And it needs to be transparent in its evaluation, and be able to report on a very regular basis what types of mechanisms and processes and policies they're putting in place within the systems to address anti-Indigenous racism. We also heard that we need to be able to build safe and supportive educational environments. So we didn't hear from lots of scholars, but we did hear from a few. And from the few that we heard, we understood that one of the things is needed is an educational environment that is safe for Indigenous people as students, whether it be undergrad or graduate students, as well as scholars, to be able to see themselves in these spaces and to have Indigenous knowledge valued and centered in their work, and that it be seen as valid and credible, and given space in all of its forms, not just in the teaching aspects, but also in the evaluation aspects, in the research aspects, and how data is collected and shared from an Indigenous perspective is to be seen as evidence as credible as mainstream evidence. And so we heard that there needs to be greater institutional support for bringing Indigenous Indigenous learners into this environment that needs to be safer, where Indigenous students can see themselves and hear their realities and experiences. And it must be rooted in those culturally based expertise, and having access to culture, recognizing it is a foundational piece to working with Indigenous people, that needs to be a foundational part to their training as Indigenous people, to work with their relatives. The fifth was to build a safe and supportive working environment for for the Indigenous workforce. So we heard that they often, in non-Indigenous organizations, are alone. They're often expected to do a lot. And this is not just, I think, in mental health and addictions system, but I think also in our educational system. So they often feel isolated and alone. There's lots of pressure for them to respond and to hold all of the knowledge around Indigenous people, or about Indigenous ways of working and knowing and being. And so there were recommendations about looking at cluster hires to support sort of that feeling of isolation, and to be able to build up sort of a support network, working and partnering with local Indigenous communities. So there is sharing of knowledge and opportunities for mentorship, ensuring pay equity, and then developing a variety of leadership training and mentorship programs that Indigenous staff could participate in to build their skills and ensure they're getting access to quality learning environments. The sixth was to increase access to care overall for Indigenous people. And we heard that one of the ways to do that is to really look at how we can co-design mental health and addictions programs and services with mainstream and Indigenous organizations or Indigenous communities, and together create programs and services that will best meet the needs of the community, of the Indigenous people in that territory or community or nation. And in order to do that, we heard quite often about the need for long-term adequate and stable funding. So right now, funding is usually on a yearly basis or on a short-term basis. And most times we heard it was very difficult to plan out programs and services with a long-term vision to address the complexity of need. We also heard it's difficult without having long-term stable funding to be able to recruit and retain people, because they are being kept for a year or less, or up to 2 years, and people are moving through rather quickly because there's no stability, I think, in the positions, really, because of that lack of funding. So needing to be able to plan and resource how to bring in a stable workforce, and how to have a system, a program and service that has a long-term plan that can build in the resources it needs to address the needs and priorities of the community and the nations. We also heard it was important to develop standards, Indigenous-based standards. And so these standards, we know there are current health system standards that are applied, but none that are specifically that are based on Indigenous ways of being and knowing and doing, and that it also has not been inclusive up till this point of Indigenous communities and organizations. And so we understood that what would be helpful was to create meaningful and reciprocal relationships where with the local Indigenous communities and organizations, where these standards could be co-developed and co-created, ensuring that the standards are come from that strengths-based perspective, again, from our own knowledge base, and that they attend to the intersectional needs of Indigenous people by looking at, as we said earlier, structural and interpersonal racism and discrimination, and how to address those intersectionalities in racism and discrimination. We also heard one of the challenges for our people is in the area of assessment and diagnosis, that much of the current tools that exist are not normed or validated off of Indigenous people. the assessment tools may not be relevant in terms of the items within the assessment tools, and the assessment tools themselves may not be adequately getting to the proper information because it is not normed or based off of Indigenous people. So some of our recommendations were to increase and give access to funding opportunities for our scholars, First Nations, Inuit, and Métis scholars, our experts and organizations and communities to begin to co-develop these tools. We use the example of the Anishinaabe, the Aboriginal Children's Health and Wellbeing Measure that was co-developed with a researcher at Laurentian University and Wik-Wimakung in Manitoulin Island. They co-created that tool, and it is owned by the community. It was developed by children for children, and those types of opportunities are not only meaningful and ensure that we're testing or assessing the things we're looking to, but it also has meaning in terms of how it can be applied. That knowledge can be applied in the community, which is what has happened with Wik-Wimakung. We also recommend in this one that there needs to be commitments at institutional and systemic levels about implementing new or different assessment tools. So acknowledging that commitment, let's say in school boards, if it was for children and youth, or if it's within various systems like child welfare systems or let's say justice systems, that there needs to be a commitment to implementing tools that are specific to Indigenous people. And that there needs to be a mandatory use of assessment tools that are seen as culturally relevant, safe, and appropriate to meet the needs of Indigenous people. And so those two really go hand in hand. And in the commitment piece, there was also an acknowledgement about the role of professional associations to uplift and support Indigenous developed tools as being most appropriate for Indigenous people. And then another recommendation was in the area of providing or supporting holistic and culturally relevant treatment practices. So ensuring that our people have access to cultural practices that we know best attend to our needs around identity, language, land, resurgence of culture. And so giving access to traditional and land-based practices, ensuring that care can be centered around family and community, which matches the framework around investing at family and community levels, being able to respond to the Indigenous social determinants of health, and ensuring that these practices are trauma-informed and healing-centered in nature. And to do this requires enhanced funding because, as I've stated earlier, there hasn't been enough funds to be able to adequately resource many of these things that we're talking about here in the recommendation section. We also heard the need to support First Nations, Inuit, and Métis research and evaluation. That although there is much more research and evaluation happening than, let's say, 10 years ago, that there still is not enough to raise up the profile of Indigenous, Métis, and Inuit research and evaluation to best support the type of data we need to collect to be able to show that our cultural practices are attending to the needs adequately. And so we talk about here the need to ground research and evaluation in local priorities based on those local metrics like the Anishinaabe, and that it be accountable to the community. And so we know some of this work is happening with FNIGC, and so our recommendation is really ongoing support of First Nations Information Governance Center, FNIGC, and those 10 regional centers across the country that are looking to support data sovereignty and the use of evaluation and research, as well as other similar Indigenous research organizations. We also heard and made a recommendation that there needs to be opportunities for First Nations, Inuit, and Métis people to be supported in reclaiming places, ways of knowing, and systems. So recognizing that We need to be able to support cultural resurgence and revitalization in our communities. We need to be able to ensure that these ways of knowing and the systems allow us to attend to the Indigenous social determinants of health and be able to create opportunities to practice deep relationality and generate collective strength. So when there are opportunities for sharing amongst First Nations, Inuit, and Métis people, whether altogether as an Indigenous group or in distinctions based, and being able to build relationships, learn from each other, recognize those collective strengths, they help in the reclaiming of spaces to increase access for our relatives to have access to the types of care and supports that they are seeking and that they require. It also means looking at the importance of generating a holistic and comprehensive continuum of care so that these places and ways of knowing are accessible in places that Indigenous people find themselves, whether that be in their communities, in small rural areas in the north or wherever that might be, including in urban centers, that these comprehensive and holistic continuum of care is available where they need it, when they need it, and how they need it. And then another recommendation was to support continued dialogue in our communities and organizations around anti-Indigenous racism. And so because we had small numbers, we'd like to continue the dialogue with Indigenous scholars and students, as well as with young people and Inuit people as well. And also to be able to expand this dialogue with multiple or intersecting identities, whether it be around disability or class or gender. So just continuing to recognize that intersectionality and identity, we often will hear and our relatives tell us they experience greater forms of racism and discrimination and stigma because of their intersectional identities, and that those need to be thought of and considered. A quote here we talk about this survey respondent noted that health disparities is the outcome of systemic racism that we've experienced, whether they be around overdose or suicide and lack of hope. And racism continues to be pervasive, not only in health systems, but in our training institutions, and can't and won't likely be corrected because these indoctrinated beliefs are sort of endemic, but rather we have to start looking at how we can decolonize systems so that we are no longer at the mercy of them, who have been really created to assimilate us. And so we have to decolonize systems to make change, was the recommendation. And so with that, I'm going to end my presentation. I have one last thing to say, and I know we're getting close to the end of our time. I just wanted to share that because we heard it would be important to get more conversation with certain groups. We are looking to host a roundtable specifically with scholars and graduate students. And I'm just looking for the poster that I want to share with you. My apologies. So we're seeking to host another roundtable discussion with Indigenous scholars and graduate students. We have one organized for January 20th. It will be done virtually. And we really would like to hear a little bit more about the experiences from our scholars and our graduate students, because we think that at least in the area of psychology, and I can speak on that sort of, when I was a graduate student a long time ago, we were told there were less than 100 psychologists in all of Canada. Dr. Anslus, who's part of the NEAR, shared with me about 5 years ago that there is less than 100 in the field of psychology in Canada. So we have not made any strides or advances in making this a safe place, and at least in the psychology training. I know there are more social workers, but we need to hear a little bit more so we can talk and make some recommendations with professional associations and with institutions about how do we make changes so that we can build our workforce, our Indigenous workforce, to better serve our people. Many of our relatives say that they feel most comfortable talking to somebody who understands and has lived their experiences. And so we have a bit of a responsibility to build up our workforce to be able to do that. And so we're hoping to hear from all of you about your experiences of racism and discrimination as it relates to mental health training, and to understand some of the best practices that might be out there. And so we're hopeful that you'd be interested in participating. So if you are, there is a QR code here, or a link. We encourage you to scan it and to register, or you can reach out directly to our assistant who is helping us with this, Trisha Trudeau, at her email address below, trisha.trudeau@fpwc.ca. Or you can call her and she'll get you registered. And with the registration, you will get a Zoom link to participate. And we do have an incentive for participation. So we do hope that you'll join us in a roundtable talking specifically to scholars and graduate students. So miigwech.
Miigwech, Brenda, for that amazing presentation. There was so much important information shared with us today. We do still have a couple minutes for questions if folks want to pop those into the Q&A, and I will also share the poster that you shared with everyone here as well. So if you didn't get a chance to get that QR code, we will be circulating that too.
Shanti, I'll just say, as maybe people are putting anything into the chat, our report is out. So although we're collecting more information, it'll come out as sort of like an addendum to the report. So if people are interested in the report, I can either send you a link to that, or I believe we also have it on our website if people would like to see the full report.
Okay, great. I'll have a look. Yeah, someone just popped in saying that they would like to see the report. So I can look for that on your website and make sure to circulate that to participants as well.
Great.
Okay. So we'll just give it a minute here to see if folks want to ask any questions. And like I said as well, if you did prefer to verbally ask, I can also give you enable the speaking permission. All right, so we have a question here in the chat. It says, how can those of us who work in the planning side of the health system but don't make decisions support the recommendations?
I think there's a space, this isn't just at a decision-making level. I think there's a space in terms of being able to develop relationships with local Indigenous communities, to understand their experiences and to identify service gaps and service needs, and how to reduce barriers. I think that doesn't necessarily come from a decision-making process, but I think when we develop relationships and we hear from people, it can build trust in folks to begin to want to access some services. So when we go into communities and make ourselves available and visible and answer questions and understand the realities of what types of services are available, that in and of itself begins to help, I think, our communities understand sort of what's available, and how they could link back to community-based services. And I know I'm talking mainly from a First Nations perspective, sort of an on-reserve perspective, but that has come up more times than I'm surprised by. I think, that local non-Indigenous organizations working, less than 50 kilometers or 20 kilometers from a local Indigenous community aren't aware of the services. And so they are not linking back to services. They're not finding ways of perhaps partnering and working together to offer services that come from local Indigenous knowledge and practices, and not being able to help folks navigate to what they need. So I think that could be helpful. The other thing for me as a service provider working in a non-Indigenous organization, we all have a responsibility within our organization for quality care. And so being part of committees on quality care in the mental health system and asking about what we are doing to ensure we're providing culturally safe care, how we're addressing anti-Indigenous racism, asking those questions and making our own systems accountable. There's a lot we can do, and it means knowing a little bit about understanding things like the United Nations Declarations on the Rights of Indigenous People, and they have the right to good quality healthcare. They have a right to determine their form of healthcare. Being able to give that information and say that Canada is looking to adopt UNDRIPA. I know it has been adopted in BC, and other provinces have had those conversations. So if we adopt it, how are we ensuring that we're carrying out the act of UNDRIP? And even the TRC call to actions are another thing that could be brought forward in the health system, in the mental health system, in terms of how are we enacting these and what can we do to do that. Asking about regular, ongoing, mandatory training around cultural safety, anti-Indigenous racism. There is some great training out there. Some professional associations are beginning to adopt some of those trainings. And I believe in the next few days to come, I did see that the Canadian Mental Health Association is planning to make a national formal apology for the racist and genocidal acts that they've contributed to with Indigenous people. And so I encourage us to listen to that apology, to hear what they plan to do, and to think about what do our other forms of the mental health system need to do, not just to make apologies, but to make meaningful change similar to what the Canadian Medical Association has started. And I think that's where CMHA got their decision to make this apology. I know the Canadian Psychological Association has something in writing, but if you are a part of the Psychology Association, asking what they're doing to enact the apology, how they are going about attending to making changes in assessment tools that are often discriminatory in some way against Indigenous people and often causing misdiagnosis, like those are things that we can all attend to.
Miigwech, and he just, there was a response in the Q&A just saying, very wise and actionable suggestions, thank you. And great news about the CMHA apologizing. So more organizations need to follow suit. Yeah, for sure. All right, well, we're right at noon. So I will go ahead and pass it to Clay to do our closing. And I just want to say miigwech for taking the time to be with us at the Ontario NEAR, Dr. Restoule. We really appreciate it. I know I learned a lot today, so I'm looking forward to having a closer look at that report. Miigwech.
Okay, Miigwech. Thank you, sister. I always enjoy listening to you talk. I could sit here and listen to you all day and just and it gives me such joy and knowing that people like you are out there doing the work that needs to be done to fight this problem. And it is a problem, and it's fixable. And then one of them is, it's a fixable problem. And so get to work. And I just say to them, to young people, everything. So thank you for that. And thank you for that memory and yeah, that's right. We did work in corrections that was a long time ago. I didn't have gray hairs back then.
Me
So,
either.
yeah, so, and all of that. So yeah, that was a blast from the past. Oh, those were interesting and very, yeah, challenging times. But you know, we did some good work there, and I'm still friends with some of them who made it out of there. Yeah. So there's Yvonne Johnson there, Joey twins, and all of them. You know, I still see Joey. All right, she's out now, 20 years. So, you know, she just did her time, and she's doing amazing. She's a motivational speaker and everything. She's doing her work. So yeah. So with that, thank you for that. So I'll just close and I just say miigwech and thank you for all the good work you do, and good to see you again.
Yes, miigwech.
Miigwech. Take care, everyone.
Take care.